Hello everyone. Now I'll be discussing question on cardiology. So we have a 62-year-old man and he come to you for evaluation of 6-month history of intermittent pain chest. Substernal pain, tightness, pain that occur when he walks quickly and climbs stairs. The symptom lasts for about 10 minutes, slowly fade away with rest. Episode do not happen at rest. He is a known case of CAD with coronary artery bypass grafting surgery 7 years ago. By this, up to this, we can analyze. He still has coronary symptom of angina, and now, despite having coronary artery bypass, he still persists to have symptom. That's what we get conclusion so far. He also have hypertension, hyperlipidemia, BP at the moment is 140/78, normal range. Pulse is again in the normal range. Treadmill test is performed 7 minutes into test, patient develop pain chest and treadmill is stopped. Sublingual nitroglycerin is administered and he almost immediately relieves the patient pain. Now the question is for the predominant mechanism responsible for rapid pain relief in this patient. The answer is decreased left ventricle wall stress. So this patient has a classical presentation of chronic stable angina. The point I mentioned in the question also. Exertional pain chest relieved by rest. Okay. And rapid relief of his symptom followed administration of sublingual nitroglycerin. NTG is a short form of nitroglycerin. This is the classical. So exertional pain chest relieved by taking rest is the reason that why we can think we are dealing with a case of angina, stable angina to be more precise. And we gave nitroglycerin, the pain got relief. Why? This anti-ischemic effect is made by direct vascular smooth muscle relaxation caused by systemic venodilatation. So what happened when we gave nitroglycerin? It mainly dilate the peripheral venules. So in that way, it reduces preload. Why preload? Because the whole blood is pulled into peripheral tissues. So that's why it will reduce preload. As it is dilating the venous, so increases the peripheral venous capacitance. I am sure you are well aware the capacitance vessels are venules and resistant vessels are arteriole. Okay, so it is dilating the vein, so it increases the capacitance vessels, so that more and more blood is pulled into peripheral tissue. So a decrease in cardiac output, decrease in cardiac filling. Why? Preload is reduced, cardiac filling is reduced on the right side. It results in decrease in left ventricle and diastolic and left ventricle and diastolic volumes. So ultimately, the less blood is coming to the right side, and ultimately, in due course of time, it reduces left ventricle and diastolic and left ventricle and systolic volume. This in turn lead to reduction in left ventricle systolic wall stress. Definitely, the volume is less, stress will be less, and it will decrease in oxygen demand, and that result in relief in the pain of angina. So this is the mechanism of how it has got anti-ischemic effect and how it is going to relieve the pain in case of angina. Now, one more thing. Most of the time, people think is it due to coronary dilatation. No. Although nitrate acts as a coronary vasodilator also. That means they dilate the coronary artery also. This is via direct relaxation of coronary vascular smooth muscle. But beneficial effect of this is not much. This is very, very important point to know, that main effect is via reduction in the wall stress, although it's a coronary vasodilator, but that is not the main mechanism. Now, one more thing. When we use nitrate, sometimes it may have bad effect also. How come? Whenever the coronary ischemia is there, let us say this one coronary ischemia is there, and this area was reduced blood supply. By default, body will try to dilate this coronary artery or arteriole, to be more precise. So, coronary arteriole in the area of limiting stenosis are already dilated by the innate mechanism of hypoxia. The body will try to dilate this by innate mechanism. Okay, and this try to maintain the resting blood flow across the stenotic lesion. Right. Well, now when you do the nitrate, when you give nitrate, so what happens? It tend to dilate the normal arterioles. This is a normal arteriole, and now it become like this. So it become like this. Okay. So it has become more dilated. So definitely this will like to more and more blood will like to go in this normal blood vessel rather than going to stenotic vessel. Rather, flow from the stenotic vessel will be diverted toward the normal vessel. So it will lead to paradoxical ischemia, or paradoxical left, a less amount of blood will go into stenotic area. So coronary vasodilatation paradoxically decreases coronary perfusion across the stenotic lesion because the blood has been diverted to the normal side. So by diverting blood flow to arterioles supplying the normal myocardium. So I hope you have understood why it is going toward the normal side. Let's look into other option. Decreased left ventricle contractility or negative chronotropic effect. Beta blocker exert the anti-angiogenic effect via decrease in heart rate. Okay, that is negative chronotropic effect. And they decrease the contractility also, decrease contractility, negative ionotropic also, and thereby they can reduce the oxygen demand. But this is not the effect of nitrates. Nitrates, they don't have a direct effect on chronic chronotropic. That means they do not affect directly, they do not increase heart rate. They may cause decreased inotropy due to decreased preload. They reduce the preload. They reduce the cardiac contractility by reducing preload. But the anti-angiogenic effect is through the direct primary due to reduction in the wall stress, as I mentioned in the previous slides. Well, we have a diltiazem, which is a type of calcium channel blocker. Stop the video. I have a question for you. Usually, calcium channel blocker are not used in routine case of coronary artery disease. We have many better options to use. Okay, now the question is, diltiazem is specifically used in which type of coronary artery disease? Write down the answer in your copy. Well, the answer is we use in vasospastic angina, which is so-called Prince metal angina, where there is coronary spasm is there. And that can lead to ischemia. And now one more question for you. Write down the answer. Suppose there is one patient who comes with acute pain chest due to vasospasm. And we know very well it causes vasospasm, which is reversible also if you give it drug in time. Now question is, what is the ECG finding in this particular case? Stop the video, write down the answer. Well, the answer is, in this case, we get ST segment elevation like this. Well, this we see in acute myocardial infarction also. But this finding we see in Prince metal angina also. But in usually it is angina is there. In this, cardiac enzymes will be normal. In such cases, diltiazem has a special role to play. Now let's look into other option. Dilatation of small arteries. Low dose, those we use like sublingual nitroglycerin, they have only modest effect on the arterial and arterial dilatation. But they cause minimum or no change in systemic vascular resistance, which is primarily controlled by the arterial constriction. So they don't have much effect. So that's why mainly the venodilatation, not the arterial dilatation. So after load, which is governed by vascular resistance, doesn't change much. Golden line to remember: anti-ischemic effect of nitrate is mediated via systemic vasodilatation with decrease in left ventricle and diastolic volume, decrease in wall stress resulting in decreased myocardial oxygen demand, and that relieves the pain. Thank you very much.